We've got a very interesting guest today, and I'm excited about it because he practices both cardiology and oncology, which I think is cool. So I'm going to introduce Dr. Dan Lenihan right now. So hold on one sec. Here we go. All right. So Dr. Lenihan has been active in cardio-oncology and heart failure for over 25 years. The main focus of his efforts have included hemodynamic assessments, angiogenic growth factor responses, and novel cardiac biomarkers, as well as optimal methods to prevent or detect heart failure at the earliest stage possible in patients undergoing treatment for cancer. He's previously held positions at MD Anderson Cancer Center in Houston, Vanderbilt University in Nashville, and Washington University in St. Louis. He's now currently the director of cardio-oncology and heart failure at St. Francis Healthcare in Cape Girardeau, Missouri. So I'd like to introduce Dr. Dan Lenihan, and he's going to be talking about what do I do about heart failure with amyloidosis. So Dr. Lenihan, welcome. We're excited to have you. Everybody put your hands together for Dr. Lenihan. And we're excited. So take it away, and you're on.
Super. And can you see my screen?
Yes, we can.
And hopefully it's in presenter mode there. So
it is now.
You're great. So I'm just going to talk a little bit about heart failure and amyloidosis, and it's really quite impressive, all the people that you have on this call from really all over the world. It's kind of awe-inspiring. So I really congratulate you for building this network, and I'm honored to be part of it. So
thank you.
Thank you all for joining. And feel free to raise questions at any point that they come up. I don't intend to, give a long lecture about the details of amyloidosis, just because I suspect that many of the people on this call know a lot about it. And also, I think we want to kind of hear what the crowd has to say. So just give you a basic overview, and specifically from a cardiac perspective. And that is, my background is in cardiology and specifically advanced heart failure. That's what I've been doing for 30 plus years. And I became interested in amyloidosis a long time ago, and it became, a passion. So it's been a big part really of the last 20 or 25 years of my practice. So what's exciting about it in particular is not only how interested this group is, but just all of the treatments and drug development that's happened in the last 5 or 10 years has really been profound. There's probably no other area of cardiology that I would say has as aggressive or as potentially beneficial research as in amyloidosis. So you should feel good about that. So this is a review we did a few years ago, but it certainly is applicable to current day. And just looking at the introductions in the chat, people all over the world, you could see that many of them have different manifestations of amyloidosis. So obviously, since I'm a cardiologist, the heart is the most important thing in my little world. But all these other organs are pretty important in their own right. And if amyloidosis affects them, we have to manage the cardiac issues with those other conditions in mind. So it is a systemic disease, and certainly the heart and the kidney, liver, GI tract, and soft tissue, which includes any soft tissue. I've had all sorts of strange presentations of amyloidosis that may manifest in some soft tissue, and you do a biopsy and comes back amyloidosis, and you're really kind of surprised. You really didn't see that one coming. And then, of course, peripheral and autonomic nervous system. This is a particularly challenging condition when you're talking about cardiac issues. Any cardiac issue that we use medications for is going to have some impact on your heart rate and your blood pressure typically. And in people that have a lot of nervous system disease related to amyloidosis, it's just a tremendous challenge. So for those of you out there who are dealing with this, uh, I really am praying for you and hoping that things get managed acceptably so you can be as active as possible. But anyway, these are the organs that are largely affected, and you see from this figure, uh, you know, if we're talking about AL amyloidosis, it may be more common that the kidney and the liver and the heart are affected. But in the case of ATTR amyloidosis, certainly neurologic manifestations are an important part of that picture. So this may be a little basic for the people on the call. So since I don't know everybody's background, I don't know where you are in the scheme of things. So if I'm telling you something that you already know really well, then just ignore this part. But when we talk about amyloidosis, we do, and it's interesting in the introduction there, you were asking, what type of amyloidosis a person may have. And, I saw a number of different answers, obviously, but if we think about all the proteins in the body that can form amyloid, uh, there's well over 30 that are reported. But when it comes to your average patient with amyloidosis, we really are only thinking about two types of amyloidosis. So number one, there's only a few that actually deposit in the heart. And then when we think about the two that typically deposit in the heart, and also how do we manage those conditions, it comes down to AL, or primary systemic, and that's from a problem from the bone marrow, or TTR, which is a problem from the liver. So those, if you read about amyloidosis, and I'm sure all the patients on the call have encountered this, if you went and looked up amyloidosis, it was a daunting task and it got super confusing. But if I could distill it down to these two types that you would predominantly need to be concerned about, then it's just a way of summarizing a very complex field. And if we talk about TTR, there's two subtypes of TTR. One is familial or mutational TTR. Now they are calling this variant. So it's really just a change in nomenclature, but it's still a mutational related TTR. And that means that there's, some sort of genetic mutation that has led to abnormal TTR production, which then makes it more likely to form a fibril. And then the more common version is wild type. And classically, this was called senile amyloidosis years ago. And then over time, they've changed the name there, and now it is referred to as wild type. And the key thing to remember about TTR is what it stands for, and it's transthyretin. So it transports thyroxine and retinol, or vitamin A. So this is a critical piece, because the targets of therapy could have an impact on those things. And that's TTR is conserved in everyone throughout their lifetime. So it's obviously an important thing. It's this abnormal TTR that we're trying to get rid of. So when we talk about cardiomyopathy, this slide does say, ATTR, but I would say AL cardiomyopathy has similar problems. So they're not always exactly the same, but certainly cardiovascular manifestations of ATTR or AL are pretty similar. And then the neurologic manifestations really complicate matters. So from a cardiovascular point of view, the most common condition is heart failure, and that may present as fatigue or dizziness or shortness of breath, edema or chest pain or some other symptoms. And I'll give a slide that has a number of other symptoms that could be indicative of heart failure. And then atrial fibrillation is a rhythm problem that makes it more difficult for your heart uh, to function properly. And then the medications that we use for atrial fibrillation further complicate the matter. So these two conditions are big enough problem on their own, but when you put it in the context of amyloidosis, it obviously becomes quite a challenge. When we talk about neurologic conditions, I'm not a neurologist, so I should just, keep it light on the neurology side. But basically, peripheral neuropathy and autonomic neuropathy are the two biggest categories, and they really make it difficult for a lot of our common treatments, especially in the cardiovascular world. So how can we actually help educate our patients? So first off, when we talk about heart failure, what are the symptoms of heart failure? And these are just some of them. You could make this list extremely long and, really overwhelm people. But the bottom line is that there are mild symptoms that potentially could indicate heart failure. And then there are more severe ones that are sort of the cardinal symptoms of heart failure. And those include, shortness of breath, whether it be at rest or with activity, definitely fatigue, weight gain, increased abdominal girth or, swelling in your abdomen or belly and in your legs. And then difficulty sleeping, you have to sleep sitting up, uh, coughing, decreased exercise tolerance, any abnormalities of your heart rate, whether it be slow or fast, or you're just feeling them uh, in an abnormal pattern. So these are just the more common. There are many different less common symptoms that could be a manifestation of heart failure. And when we talk about treatment of heart failure for amyloidosis specifically, this is where it gets pretty difficult, because if we were just talking to a general audience and you ended up with heart failure as a condition, there's a whole range of medicines that we commonly use, and we titrate them to maximum tolerated doses. We then start talking about defibrillators and pacemakers. And then if your condition gets more severe, we talk about really advanced therapies, which include, transplant or a ventricular assist device. So I'm not going to talk about any of those things. Those are, huge topics in and of themselves for the treatment of heart failure. But how you relate that to amyloidosis is summarized honestly on this slide. So the key thing about patients with significant cardiac amyloidosis is that our traditional therapies are going to be difficult. You're not going to be able to tolerate them because your blood pressure or heart rate will be too disturbed to be able to use our traditional medicines. So the one thing that we can count on is that you need to restrict your salt intake because your heart is holding on to salt in response to your body's challenges. The heart and the neurohormones that are flowing through your body are telling your body, hold on to that salt with everything you got. So any amount of salt that you take in is going to result in worsening edema and potentially, electrolytes and kidney function and other stuff are going to become a problem. So salt restriction and then diuretics to manage the fluid, those are basics. That's what everybody with cardiac amyloidosis is going to end up with that as your primary treatment. And then the other part is in certain patients, especially those with AL, amyloidosis, uh, what they have is a protein production issue in their body. And typically, those proteins that are created by the bone marrow are very big, compared to other molecules in your blood. And those proteins bind together and then they go and bind to the kidneys filtering system. So over time, that protein deposition harms the kidney and it can no longer filter appropriately. And where that shows up is that your body starts to lose protein through the kidney, where normally your kidney would hold on to it. And once you start losing protein through your kidney, then this whole problem with edema and swelling and low blood pressures and all of that, it only gets worse. So that's really what the treatments for AL partly are intended to protect the kidney from the damage from those proteins. And then also, what happens is if the protein in your blood is getting low, then all of the issues of swelling, et cetera, are made worse. And then when we talk about common treatments for heart failure, all of these classes of medicines that I have there are pretty common. Those are things that people use all the time. And you have a great difficulty using those types of medicines in people that have cardiac amyloidosis. And then, as I mentioned before about autonomic dysfunction, it is primarily a neurologic problem, but where it affects the cardiovascular management is that you have difficulty with blood pressure. So your blood pressure may drop significantly if you stand up, and then there are a host of medicines that we can use. Although none of them are really great, they might help some, but none of them like solve the issue. So it's still a challenging condition. And then treatment of atrial and ventricular arrhythmias, that's just basically summarizing that patients with cardiac amyloidosis have a lot of rhythm problems, and how we manage them is greatly influenced by how they tolerate typical heart medicines. So this slide is not to be studied. It's to just be sort of generally viewed. This is a list of drugs that are sometimes used to help manage autonomic dysfunction or hypotension. And you can see over there, they're complex. And, we do use them at times, but hopefully we can manage the condition without having to use these medicines. If we can do that, then we're much better off. In the bottom part of this slide, over to the right, these are non-medical treatments that are usually very helpful. And so if you are having problems with a low blood pressure, water intake is your most immediate treatment. It can make a difference in 5 or 10 millimeters of pressure in your blood pressure just in a matter of minutes. So I highly encourage, significant water intake for patients with cardiac amyloidosis. And then some of those other things mentioned, including support hose. You could even get these abdominal compression devices. Those are quite a bit more detailed. So I won't talk about those unless somebody has a specific question. And then when we talk about rhythm issues, I'm not I'm not going in any great detail because this issue becomes very detailed. We have uh, trouble with our usual medicines in terms of what we might use to manage AFib, and then patients in AFib are more likely to have a blood clot and possible stroke. But in the case of cardiac amyloidosis, those risks are even higher. So it's a significant issue, and trying to prevent those problems is really a key. And then, of course, most patients with cardiac amyloidosis will have some evidence of conduction disease. Uh, Hopefully, that can be a minor problem, but it certainly leads to the need for a pacemaker or defibrillator in certain cases. And then just a word about genetic testing. This is a summary slide. Things you really have to individualize these decisions, to the patient, and their specific family history. But in general, there's no specific genetic testing in patients who have AL. But in patients who have either suspected ATTR or confirmed ATTR, then it's really expected that they would need to have genetic testing for sure. And that's because roughly about 15% of patients with ATTR will have a mutation. And then the treatments for the mutational TTR is, very specific. So only if you have that mutation are you eligible for those treatments. And so uh, it's imperative that you do genetic testing in that case. And then, of course, a lot of family members, you might consider them to be screened if appropriate. Uh, Certainly, siblings, that is probably going to be an important thing. Uh, Descendants, children or grandchildren. There's a lot of details about, when you do genetic testing, et cetera. So I won't go into all that, but needless to say, uh, one family member who's identified as having a genetic mutation, you have to consider how that could impact the other family members. And then I won't go over this specifically, but sometimes patients will develop amyloidosis, and it is not AL and it is not ATTR. And in those situations, they may have a very rare mutation that is not related to the TTR gene. And so in those situations, you have to do what's called whole gene sequences. So that's very specific. And, anytime we get to that level of detail, we usually want to get uh, an expert location involved. And for us, typically that's Mayo Clinic, but there may be other places around the country that have that sort of expertise. And then this is just a slide kind of summarizing some of the drugs that are being used right now. This slide is a few years old, but thankfully, all the big drugs out there are on it. Some of them are their chemical name, so you may not recognize them, but nonetheless, several drugs have been approved by the FDA in the last couple of years that are on this list. So it is a pretty up-to-date list in terms of treatment. The top part is ATTR and the bottom part is AL. So we put all this together, cardiac amyloidosis. Uh, if I could, just emphasize something, it would be that first bullet, first and second bullet, where your volume status is very important in terms of how you're going to tolerate any cardiac medications. So sodium restriction is absolutely essential. And then, prominent water intake is usually very helpful. Many times, if you come into the hospital for heart failure, almost every nursing place in the country, as far as I can tell, they're going to fluid restrict you. They'll say, don't drink, 2 glasses of water in a day or something. I do not agree with that, but that's written in stone in most hospitals. So I'm sure anybody who's been admitted to the hospital would have experienced that. So it's a fact at every hospital that I've ever been in. So, and then as mentioned earlier, typical medicines for heart failure are not very well tolerated if you have cardiac amyloidosis. And then arrhythmia issues are common, very common, and they're always complex. And the other key point is that the rate of cardiac thrombi is really unacceptably high in patients with amyloidosis. So you have to be very concerned about those issues. And as I also mentioned, the treatment for AL and ATTR has really developed rapidly. And I think it's absolutely transforming the outcomes for patients with cardiac amyloidosis. So a very bright future is the way it seems. So I think I'll stop there and open up to questions. I know there's been a lot of stuff going on in the chat. So Dan, I don't know if you want to navigate all that.
Yes, I will. If you could obviously not pull down your share, and we'll get people on board, and we'll see who's got some questions. So we got John with his hand up, and we'll start with John. So John, fire away.